I'm Dr. Jules Cohen. I am a clinical associate professor of medicine at Stony Brook University. I specialize in taking care of women with breast cancer. When I was an oncology fellow, I sort of gravitated towards the breast cancer clinic. I liked the patient population. I liked the doctors who took care of these patients. I liked the scientific content and the medical content of the field. I liked the fact that there was a very vocal advocacy community that was pushing a lot of research, and that there were probably some of the most frequent and significant breakthroughs in oncology taking place in the field of breast cancer. And I liked that most of our breast cancer patients do well. So in practice, KISQALI is my go-to CDK4/6 inhibitor because it has overall survival benefit. And again, that is the gold standard in medical oncology, that we want to keep patients alive as long as possible, and that is our sort of prime directive. KISQALI is the only CDK4/6 inhibitor with a statistically significant overall survival benefit across all three major clinical trials in HR-positive, HER2-negative metastatic breast cancer. The three Mona Lisa trials demonstrate that KISQALI can be used across a wide range of patients, hopefully corresponding to the patients that you see in your practice. We know that KISQALI is effective in premenopausal patients and postmenopausal patients. We know that KISQALI is effective in combination with a non-steroidal aromatase inhibitor or with a parenteral SERD, such as fulvestrant. And in my personal experience as a medical oncologist, I've used it across the board in all of these patients, and again, I have found it to be effective and a great addition to our armamentarium in breast cancer. The first few words that come to mind when I think of KISQALI for HR-positive, HER2-negative metastatic breast cancer, median overall survival, which means more life for living. What impresses me most about KISQALI, in my experience, is that this little pill, this 3 little pills, can have such a profound effect on a person's life. You take these 3 little pills and another pill that's your anti-estrogen pill, and you can be getting your full, complete treatment for metastatic breast cancer for perhaps a few years. And again, if it results in a prolonged median overall survival versus patients who did not get KISQALI, then I think I would be very loath to deprive my patients of that potential benefit.
Indications. KISQALI is indicated for the treatment of adults with hormone receptor, HR-positive, human epidermal growth factor receptor 2, HER2-negative, advanced or metastatic breast cancer, MBC, in combination with an aromatase inhibitor as initial endocrine-based therapy, or fulvestrant as initial endocrine-based therapy, or following disease progression on endocrine therapy. Important safety information. Interstitial lung disease, pneumonitis. Severe, life-threatening, or fatal interstitial lung disease, ILD, and/or pneumonitis can occur in patients treated with KISQALI and other CDK4/6 inhibitors. In patients with advanced or MBC, Mona Lisa 2, Mona Lisa 3, Mona Lisa 7, 1.6% of patients had ILD pneumonitis of any grade, 0.4% had grade 3, 4, and 0.1% had a fatal outcome. Additional cases of ILD pneumonitis have occurred in the post-marketing setting, some resulting in death. Monitor patients for pulmonary symptoms indicative of ILD pneumonitis, which may include hypoxia, cough, and dyspnea. In patients who have new or worsening respiratory symptoms suspected to be due to ILD or pneumonitis, interrupt KISQALI immediately and evaluate the patient. Permanently discontinue KISQALI in patients with severe ILD pneumonitis or any recurrent symptomatic ILD pneumonitis. Severe cutaneous adverse reactions. Severe cutaneous adverse reactions, SCARS, including Stevens-Johnson syndrome, SJS, toxic epidermal necrolysis, TEN, and drug-induced hypersensitivity syndrome, DIHS, drug reaction with eosinophilia, and systemic symptoms, DRESS, can occur in patients treated with KISQALI. If signs or symptoms of scars occur, interrupt KISQALI until the etiology of the reaction has been determined. Early consultation with a dermatologist is recommended to ensure greater diagnostic accuracy and appropriate management. If SJS/10 or DIHS stress is confirmed, permanently discontinue KISQALI. Do not reintroduce KISQALI in patients who have experienced scars or other life-threatening cutaneous reactions during KISQALI treatment. QT interval prolongation. KISQALI has been shown to prolong the QT interval in a concentration-dependent manner. Avoid KISQALI in patients who are at significant risk of developing Torsades-Dupont, TDP, including those with congenital long QT syndrome, uncontrolled or significant cardiac disease, recent myocardial infarction, heart failure, unstable angina, bradyarrhythmias, uncontrolled hypertension, high-degree atrioventricular block, severe aortic stenosis, or uncontrolled hyperthyroidism, electrolyte abnormalities. Taking drugs known to prolong QT interval and/or strong CYP3A inhibitors, as this may lead to prolongation of the QT-CF interval. Based on the observed QT prolongation during treatment, KISQALI may require dose interruption, reduction, or discontinuation. In patients with advanced or MBC, MONALEESA-2, MONALEESA-3, and MONALEESA-7, who received 600 mg KISQALI plus NSAI or fulvestrant, 15 of 1,054 patients, 1.4%, had a greater than 500 milliseconds post-baseline QT-CF value, and 61 of 1,054, 6%, had a greater than 60 milliseconds QT-CF increase from baseline. QT-CF prolongation was reversible with dose interruption. The majority of QT-CF prolongation occurred within the first 4 weeks of KISQALI. There were no reported cases of Torsades-Dupont. In MONALEESA-2, in the KISQALI plus letrozole treatment arm, there was 0.3%, sudden death in a patient with grade 3 hypokalemia and grade 2 QT prolongation. No cases of sudden death were reported in MONALEESA-7 or MONALEESA-3. Perform electrocardiogram, ECG, in all patients prior to starting KISQALI. Initiate treatment with KISQALI only in patients with QT-CF values less than 450 milliseconds. Repeat ECG at approximately day 14 of the first cycle and as clinically indicated. Monitor serum electrolytes, including potassium, calcium, phosphorus, and magnesium, prior to the initiation of KISQALI at the beginning of the first 6 cycles and as clinically indicated. Correct any abnormality before starting KISQALI. Increased QT prolongation with concomitant use of tamoxifen. KISQALI is not indicated for concomitant use with tamoxifen. Avoid use of tamoxifen with KISQALI. In MONALEESA-7, the observed mean QT-CF increase from baseline was greater than 10 milliseconds higher in the tamoxifen plus placebo subgroup compared with the nonsteroidal aromatase inhibitor, NSAI plus placebo subgroup. In the placebo arm, an increase of greater than 60 milliseconds from baseline occurred in 6 out of 90, 7% of patients receiving tamoxifen, and in no patients receiving an NSAI. An increase of greater than 60 milliseconds from baseline in the QT-CF interval was observed in 14 out of 87, 16% of patients in the KISQALI and tamoxifen combination, and in 18 out of 245, 7% of patients receiving KISQALI plus an NSAI. Hepatotoxicity. In patients with advanced or MBC, drug-induced liver injury and increases in transaminases occurred with KISQALI. In patients with advanced or MBC, MONALEESA-2, MONALEESA-7, and MONALEESA-3 treated with KISQALI, grade 3 or 4 increases in ALT and AST occurred in 11% and 8% respectively. Among the patients who had grade greater than or equal to 3 ALT-AST elevation, the median time to onset was 92 days for the KISQALI plus aromatase inhibitor or fulvestrant treatment arms. The median time to resolution to grade less than or equal to 2 was 21 days in the KISQALI plus aromatase inhibitor or fulvestrant treatment arms. In MONALEESA-2 and MONALEESA-3, concurrent elevations in ALT or AST greater than 3 times the ULN and total bilirubin greater than 2 times the ULN with normal alkaline phosphatase in the absence of cholestasis, Hy's law, occurred in 1% patients, and all patients recovered after discontinuation of KISQALI. Perform liver function tests, LFTs, before initiating KISQALI. Monitor LFTs every 2 weeks for the first 2 cycles, at the beginning of each of the subsequent 4 cycles, and as clinically indicated. Based on the severity of the transaminase elevations, KISQALI may require dose interruption, reduction, or discontinuation. Neutropenia. KISQALI causes concentration-dependent neutropenia. In patients with advanced or MBC, MONALEESA 2, MONALEESA 7, and MONALEESA 3, who received KISQALI plus NSAI or fulvestrant, 75% had neutropenia. 62% had grade 3-4 decrease in neutrophil count based on laboratory findings, and 1.7% had febrile neutropenia. The median time to grade greater than or equal to 2 neutropenia was 17 days. The median time to resolution of grade greater than or equal to 3 neutropenia to grade less than 3 was 12 days. Treatment discontinuation due to neutropenia was required in 1% of patients. Perform complete blood count (CBC) before initiating therapy with KISQALI. Monitor CBC every 2 weeks for the first 2 cycles, at the beginning of each of the subsequent 4 cycles, and is clinically indicated. Based on the severity of the neutropenia, KISQALI may require dose interruption, reduction, or discontinuation. Embryo-fetal toxicity. Based on findings from animal studies and the mechanism of action, KISQALI can cause fetal harm when administered to a pregnant woman. Advise pregnant women of the potential risk to a fetus. Advise women of reproductive potential to use effective contraception during therapy with KISQALI and for at least 3 weeks after the last dose. Adverse reactions. Most common, incidence greater than or equal to 20%. Adverse reactions include infections, nausea, fatigue, diarrhea, vomiting, headache, constipation, alopecia, cough, rash, and back pain. Laboratory abnormalities. Across clinical trials of patients with advanced or metastatic breast cancer, the most common laboratory abnormalities reported in the KISQALI arm, all grades, pooled incidence greater than or equal to 20%, were leukocytes decreased, neutrophils decreased, hemoglobin decreased, lymphocytes decreased, AST increased, gamma-glutamyl transferase increased, ALT increased, creatinine increased, platelets decreased, and glucose serum decreased. Please see full prescribing information at KISQALI-HCP.com. MONALEESA 2 was a randomized, double-blind, placebo-controlled Phase 3 study of KISQALI 600 mg, dosed orally once daily for the first 21 days followed by 7 days off, resulting in a complete cycle of 28 days, plus letrozole, N equals 334, versus placebo plus letrozole, N equals 334. In postmenopausal patients with HR-positive HER2-negative metastatic breast cancer who received no prior therapy for advanced disease. Patients continued treatment until disease progression or unacceptable toxicity. OS was a secondary endpoint, PFS was the primary endpoint. At a median follow-up of 80 months, median OS was 63.9 months with KISQALI plus letrozole, which had a 95% CI of 52.4 to 71.0. versus 51.4 months with placebo plus letrozole, which had a 95% CI of 47.2 to 59.7. HR equaled 0.765 with a 95% CI of 0.628 to 0.932, and a p-value of 0.004. MONALEESA 3 was a randomized, double-blind, placebo-controlled Phase 3 study of KISQALI 600 mg, dosed orally once daily for the first 21 days followed by 7 days off, resulting in a complete cycle of 28 days, plus fulvestrant, N equals 484, versus placebo plus fulvestrant, N equals 242, in postmenopausal patients with HR-positive HER2-negative metastatic breast cancer who received no or only 1 line of prior ET for advanced disease. Patients continued treatment until disease progression or unacceptable toxicity. OS was a secondary endpoint, PFS was the primary endpoint. At a median follow-up of 39 months, median OS was not reached with KISQALI plus fulvestrant with a 95% CI, 42.5 to not reached, versus 40 months with placebo plus fulvestrant with a 95% CI, 37.0 to not reached. HR equals 0.724 with a 95% CI, 0.568 to 0.924. P equals 0.00455. MONALEESA 7 was a randomized, double-blind, placebo-controlled Phase 3 study of KISQALI 600 mg, dosed orally once daily for the first 21 days followed by 7 days off, resulting in a complete cycle of 28 days, plus ET, NSAI or tamoxifen plus goserelin, N equals 335, versus placebo plus ET, NSAI or tamoxifen plus goserelin, N equals 337, ITT, in premenopausal patients with HR-positive, HER2-negative metastatic breast cancer who received no prior ET for advanced disease. Patients continued treatment until disease progression or unacceptable toxicity. In the subgroup of patients who received tamoxifen, an increased risk for QT prolongation was observed. KISQALI is not indicated for concomitant use with tamoxifen. Efficacy results are from a pre-specified subgroup analysis of 495 patients who received KISQALI, N equals 248, or placebo, N equals 247, with an NSAI plus goserelin, and were not powered to show statistical significance. OS was a secondary endpoint, PFS was the primary endpoint. At a median follow-up of 35 months, median OS was not reached for KISQALI plus an AI plus goserelin with a 95% CI, not reached to not reached, versus 40.7 months with placebo plus an AI plus goserelin with a 95% CI, 37.4 to not reached, HR equals 0.699 with a 95% CI, 0.501 to 0.976. At a median follow-up of 35 months, statistical significance was established for overall survival in the ITT population. HR equals 0.71 with a 95% CI, 0.54 to 0.95, P equals 0.00973.